Welcome, colleagues. Today, we're going to do a focused explainer on a really critical topic in our field. What's really happening to the patellofemoral joint when we use the suprapatellar approach for tibial nailing?
So we all face this clinical question, right? We choose the suprapatellar approach because it gives us these beautiful anatomic reductions, especially in the proximal third. But what's the trade-off? What's the true iatrogenic risk we're exposing that patellofemoral cartilage to? Okay, let's just cut right to the chase here. The bottom line from all the available evidence is this. Yes, some cartilage changes do happen, but for the most part, they seem to be low grade and don't actually cause problems for patients in the short term. The key thing, though, is that severe damage while wear is a very real possibility, and it's almost always avoidable with meticulous surgical technique. Now, this is where it gets really interesting. When you start digging into the literature, you find this apparent paradox. It's like you're reading a tale of two completely different data sets that seem to be telling us opposite things. And this slide really nails that core conflict. On one side, you have the direct visualization studies, arthroscopy and imaging, and they show new chondral lesions, scuffing, even metallic debris in the joint. It looks bad. But then, on the other side, you have these massive clinical meta-analyses, and they consistently show no difference in knee pain or function at 1 or 2 years when you compare it to the old infrapatellar approach. So what gives? This really begs the question, what is the actual incidence? What's the true chondral footprint of this procedure? We need to quantify the risk, so let's break down the numbers we have. Okay, so this is some of the best direct look data we have so far. It's a key study from 2024 by Eidler and his group. What they did was perform arthroscopy both before and immediately after nailing on 36 straight patients. And what they find? One new severe full-thickness grade 4 lesion. That gives us a pretty specific number, an incidence of 2.8% for a significant iatrogenic injury. Now hold that 2.8% number in your head and contrast it with this. We have recent meta-analyses, like the big one from Wang in 2023, that include data from over 2,000 patients. And in this massive data set, you just don't see a clinical signal. There's no statistically significant increase in patellofemoral problems or worse functional scores. It seems the clinical follow-up just doesn't reflect that arthroscopic finding. And this table really lays out that variability in the literature quite nicely. You see the early work from Jacma back in 2011, a small series just noting some qualitative scuffing. Then you get the larger Sanders series in 2014, with MRIs finding really no consistent changes. Then, of course, you have Eidler's more recent work pinning down that 2.8% incidence of a grade 4 lesion. And on the far end of the spectrum, you have the case report level injuries, like the one from Lane, which we really need to talk about. Because even though the overall incidence of clinical problems seems low, we absolutely must address these documented severe injuries. These represent the worst case scenario, the significant morbidity that we are all trying to prevent. I mean, just look at this quote from that case report by Lane in 2022. A symptomatic full-thickness defect in the trochlea that we caused. This wasn't some minor scuff. This was a catastrophic injury that ultimately required a complex cartilage restoration procedure, an ACI. This is exactly the outcome we're all working to avoid. So how does this happen? Well, when you analyze these severe injuries, a pattern emerges. It's almost always linked to a technical error. The most common culprits are losing the position of that protective cannula during reaming, using the reamer as a lever against the trochlea, or just direct trauma from instruments during retraction. So this brings us to the most practical part of this whole discussion. How do we actively minimize this risk in our own ORs? What are the evidence-based steps we can take on every single case? The literature is pretty clear, and I like to distill it down to these 4 critical pillars. First, use the dedicated protective sleeve and make sure it's seated firmly against the bone. Second, and this is crucial, be absolutely vigilant about maintaining that cannulus position throughout the entire case. Third, no levering. The reamer is not a retractor. And finally, before you close, irrigate the joint thoroughly. Get any potential metallic or bone debris out of there. So let's pull all this evidence together. How do we synthesize this into a coherent, practical conclusion that we can take into our next case? Here's the crucial takeaway. The data absolutely supports the continued use of the suprapatellar approach. Its benefits are real, but its safety is conditional. It's conditional on us, the surgeons, meticulously adhering to a protective, evidence-based technique every single time. The risk is real, but it's largely in our hands to mitigate. And this really leaves us with the final and I think most critical question. Okay, the 2-year data is reassuring, but what is the 10-year fate of these joints? What happens to that low-grade chondral scuffing over the long haul? Are we inadvertently setting some of these patients up for iatrogenic patellofemoral arthritis down the road? Frankly, that remains the great unknown, and it's where our future research really needs to focus.